Thank you for the kind invitation. So I will give a general overview on Hep E, which is a much more rare virus, but I will try to convince you that you have to look for this virus in your clinical and daily practice. I will give some words on epidemiology, routes of infection, how to diagnose the virus, which are the clinical presentations, the treatment options. As you will see, there are not so much treatment options. In some chronic forms, it may be a challenge to treat the patients. Some words about prevention and future perspectives in clinical and translational research in the field of Hep E. To make it more lively, I like to start with a clinical case. This is one of my patients. He's a 72 years old man with no significant comorbidities. In particular, he had no history of liver disease, of advanced liver fibrosis, and he presented in early 2020 with a new onset jaundice. Total bilirubin was high, abdominal pain and fever. And here is the lab at the time he presented at the CHUV. So as you see, he had a very severe hepatitis with an ALT more than 1,000 and the total bilirubin more than 200. Synthetic liver function was still preserved at that point. Here, of course, I choose a case of Hep E, as this is the theme of my presentation. So this man had a positive serology for anti-HEV IgG and IgM, and a positive PCR, and specifically subgenotype 3H. We will go back to this notion afterwards, and I will show you we have in Switzerland Roger Federer and also our own hepatitis E. And this was the story of a deer. This man had 2 or 3 weeks before coming to the hospital. He went with his family to the restaurant and he ate a carpaccio of deer. And this was the source of infection. I cannot prove it. I do not have a piece of meat to do the PCR in the meat, but I'm convinced this was the source. And it was a raw deer that he ate. So what is the challenge of hepatitis E? Hepatitis E is nowadays the most common cause of acute hepatitis and jaundice in the world. And there are two very different scenarios that we have to distinguish when we talk about Hep E. The first one is in developing world, so Africa, India, Asia, where the main genotypes are genotype 1 and 2, and where the virus, the patients infect themselves with contaminated water. So this is the same way as you catch Hep A, for example, and this is really a drama. Every year there are more than 70,000 people that are dying from Hep E in non-developed world, and this is mainly pregnant women, young babies, and immunosuppressed people. And then you have the second scenario, and my presentation today will focus on this scenario, which is our scenario, is Hep E genotype 3 and 4, and here it is zoonosis. So zoonosis means that you get infected by eating, for example, contaminated pork or game meat. But there are also other routes of infection, and this is really a problem in Europe. In some regions of Europe, the seroprevalence reaches up to 86%. This is the case of the region of Toulouse in South France. In Switzerland, there was a big issue with hepatitis E some years ago in Ticino, and this was linked to the mortadella di fegato, and we will discuss this afterwards. And genotype 3 is a virus that can trigger an acute-on-chronic liver failure in a patient with an advanced liver fibrosis or cirrhosis. It can persist in immunocompromised patients, so transplant patients, patients with hematological diseases, as well as HIV patients with low CD4. And in those patients, it may progress rapidly to liver cirrhosis, and these patients are really to be treated as soon as possible. I will go into details afterwards. And this virus is also associated to neurological complications. So this is a summary of the two main different epidemiological situations. You see that all these genotypes can infect men, and for today we will focus on genotype 3 for our discussion. And basically it's like for Hep C. I mean, there are still many patients to be treated. I'm convinced that we still not did reach all the patients to be treated with chronic Hep C, and this is not the same problem with Hep E, but if you don't look for it, you don't find it. And I'm convinced that there are some patients that present with an Hep E that are diagnosed too late, and this is complicating the management of these patients and giving important liver morbidity. So, and this is the proof. In 2005, ECDC started a surveillance program. And since then, you see that there was a huge increase in the number of cases that were declared in Europe. And maybe there was an increase of the number of cases, but there was an increase of awareness, and the doctors started to look for the viruses. And as you see, 80% of the cases came from France, Germany, and UK, where the awareness is maybe higher than in other regions of Europe. And maybe you heard something about what happened in our country last year. This is data that are shared by the Federal Office of Public Health. In February-March 2021, there was an increase in the cases of Hep E. In my clinical practice, I saw in 1 month like 3 or 4 patients presenting in hospital due to Hep E. This is not usual. Usually it's 1 every 6 months maybe. So there was a huge increase that was affecting every age group, but with more important incidence in around 60 years. And this was the case for the blood donors and all patients with symptomatic Hep E. In Switzerland, we started to test blood products in 2018. And I mean, it's strange that we only started in 2018. The virus is well known, and the blood products are given to usually not very healthy people. So, I mean, it was only started to be tested in 2018. And in this epidemic, we could not find the origin. It is very probably due to food, but we could not find the source. And I wanted just to show the specific situation in Ticino, where the number of cases started to go down the last years. And this was really due to a big common effort of doctors, veterinaries, and there was a campaign to increase the awareness in the population about this sausage that is called the mortadella di fegato. And the mortadella di fegato was produced with raw liver pork. And this was the source. Since then, they increased the awareness of the patients that the consumption of this sausage was diminished, but in parallel, there was also an effort to change the way this sausage was produced, as they started testing the porks, the liver porks, before manufacturing the sausages. And this is really a nice illustration of an important work to diminish in our country the number of cases. In Lausanne, we profited from all these cases. At one point, we were the only center where the PCRs were done for diagnosis, so I collected, together with Darius and other members of our team, all the cases coming from across Switzerland. And this is very interesting that we have a very homogeneous viral swoosh, which is the 3S that is called now 3HS. And as you will see, it is a subgenotype that is specific to our country. There were also some Hep E coming from rabbits. This was the first time it was demonstrated, but I mean the key message is that there is a very homogeneous virus in our country. It's always the same one. And this is due to the fact that in Switzerland we import many products, we export also chocolate, everything, but for the pork we have our own pork. The consumption of pork in our country is mainly indigenous. So this is really the reason why we can say we have our why we postulate, we don't have the proof, but we postulate we have our own virus. So how do people get infected? There are many routes of infection. The key message is through the consumption of raw pork and game, but you may get infected through other ways. For example, I'm coming from North Spain and I go every summer to the same place and I eat the shellfish, and I found the study where more than 50% of the shellfish that we were eating were contaminated with Hep E, because you have the sea, but you also have the porks just around the sea. So this is very interesting. So we can get infected by eating other products, not only meat. And as the virus is shed in stool, you may have also human-to-human infection. There are some described cases. I mean, Hep E is somehow similar with Hep A, and you can also get infected by blood products. As I said, nowadays it is systematically tested in our country, and this is helping me for my research in collaboration with the Swiss blood donation centers. You have a question? No. But please, if something that I say is not clear, just interrupt me. I will be happy to answer. And this is the way it goes when you get infected. So you have approximately a 2-3 weeks incubation period. Then you get the symptoms. You have the increase of IgG, IgM, but what is the key message is important to say is that to catch the virus, to have a positive PCR, you have a small window. It's like 2 to 4 weeks. So when you see a patient, of course you can do the serology that will help and guide, but you should think, if you have a clinical presentation suggestive of, to do directly the PCR to have the proof, because that will impact afterwards the management. So this is the guidelines from the ECDC, so the European Association for the Study of the Liver. My chief, Darius Moradpour, of course, collaborated in these guidelines. And the key message for the diagnosis is that you have to separate immunocompetent patients from immunocompromised patients, and never forget that the serology is not helpful in immunocompromised patients. I do it for curiosity, just to know if they have antibodies or not, but I mean the PCR is really the diagnostic tool, and in immunocompetent patients, the serology, a positive IgM will give the diagnosis. In Lausanne, we do systematically the PCR, but this is a little bit biased because we have it easily. Maybe in other parts it's more difficult. And there is also an important message from these guidelines. There are all other situations where you should test the patient for Hep E, and one good example is before concluding to a drug-induced liver injury, you should test for Hep E. Approximately 5% of DILI diagnosed patients have in fact an Hep E. You should also test for Hep E in neurological complications, so I will go later on say some words about neurological complications, and you should keep in mind that in immunocompromised patients the liver test may be only slightly increased. Usually these patients, they don't have 300 or 500 of transaminases, they have maybe 100. And if they persistently are elevated, you should look for Hep E by PCR. And I will show you a case from our clinics where we had 2 years to diagnose an Hep E in cirrhotic patients. Here I like this picture to summarize the clinical presentation of Hep E, because it is like an iceberg. We only see the tip of the iceberg, the more symptomatic, the more severe cases, but also because we don't look enough for Hep E, and it would be very interesting to have a better overview. And it is also something that is strange, that we don't understand always what is the difference between the patients that are on tip of the iceberg and on top of the iceberg and in the water. I mean, in some immunocompetent patients, there are very severe presentation. They don't have liver disease, they are not taking any drug, they are not immunocompromised, and still they present. This was the case of my patient with a very severe hepatitis, and we are now trying to understand why this heterogeneity of presentation. So the clinical spectrum is wide. It may go from asymptomatic liver transaminase increase to acute liver failure. Acute and chronic liver failure in patients with cirrhosis has a very high mortality. During this period of 2021, there were 2 cirrhotics that were dead in our country from Hep E. I know 2 is low numbers, but still, when you are the one, I mean, we could have avoided maybe. And so the more severe presentation are in middle-aged elderly men. You have these extra-hepatic manifestations. I will go later on into detail. And you have these high fertility rates in pregnant women in other countries, in underdeveloped world. And you may counsel pregnant women not to travel to those regions because they may catch Hep E, and it may be a catastrophe. And of course, the chronic forms in immunocompromised patients that may lead to cirrhosis in less than 2 years. So it may progress rapidly. And just to have a general overview, this is, I think, the best study to summarize the morbidity and mortality of autochthonous hepatitis E. And as you see, up to 50% of patients that were diagnosed were hospitalized. You had some chronic forms, 6%. Some patients, 6% needed ribavirin. There were deaths, 3.3% mortality in this cohort. So this is high in my view. And the main risk factors were cirrhosis and hematological malignancy. And there were 2 acute liver failure that required liver transplant. And these patients were not patients with previous medical history. And in Lausanne, we were stricken by the impact on our cirrhotic patients, and we characterized the presentation. We collected all the cases. We now have more cases, and unfortunately, I have to say that every cirrhotic patient that I saw in hospital with an Hep E on a context of cirrhosis died. This is really a dramatic presentation, and you should think about Hep E. And one distinction is liver histology doesn't help. I mean, it's not typical for viral hepatitis. Here you see there was a steatohepatitis, typical of alcohol and NASH. But the key point is that these patients have always, not always, but in most of the cases, very high transaminases. And just some words about hepatitis E extra-hepatic manifestations. So it's 5%, 7%, depending on the series of autochthonous Hep E. Again, males are more prone to these complications than women. And the mechanism of neurological injury is not really well understood. We don't know if it's a pathogenic direct effect of the virus on the neurons or if it's a immune-mediated injury. But the main complication is what we call the personage donor. And these patients usually have only slightly increased transaminases, and this may really be very debilitating. So the typical presentation, and before the neurological symptoms appear, the patient comes to your consultation and complains of a very severe pain in the neck, in the shoulders, that is wakening them during the night, and generally after 24, 48 hours, then start to have paresthesia, loss of strength in the arms, and you really have, in the case of Hep E, a bilateral lesion of the brachial plexus, and you see that there is a scapula that starts to rise. It's what we call the scapula alata, and this is really due to the lesions of the brachial plexus, and some patients do not recover, and you may also have lesions outside the brachial plexus in the phrenic nerve. And I have a patient that still has a diaphragmatic paresthesia many years afterwards. And renal complication, this is much more rare. I never saw it in Lausanne, but I know there was recently a case in St. Gallen. So these are mainly transplanted kidney transplant patients, and they may lose the kidney, and it is a membranoproliferative glomerulonephritis induced by Hep E, and the treatment is to treat as soon as possible the virus and corticosteroids. So chronic Hep E is really the challenge in clinical practice. It is observed in immunosuppressed patients, transplant recipients, hematologic cancer, HIV with low CD4 patients. It is mainly genotype 3, but there are all other genotypes. In Hong Kong now there is a rising cases of rat HEV that is infecting immunosuppressed patients, and it may rapidly progress to liver cirrhosis in 2 years. Serology, as I said, is negative. You should test these patients for RNA, and the management is really to lower immune suppression, but this is not always evident in some patients that, for example, received rituximab to stop the hematological treatments, and then ribavirin, but there are resistances to ribavirin, so there are still some patients that are difficult to treat. And this is a case of a male patient, 60 years, that we published. We used, as you see, sofosbuvir in this patient. So he was an alcoholic, a previous alcoholic. He stopped drinking, he got the liver transplantation, and then he had always slight increased transaminases. And the doctors in the transplant unit were always asking him whether he was drinking. He was saying no, but yes, you drink. No, I do not drink. And so this was the discussion for many years. And when they called me for advice, I looked back at the serotech that we had. We had a serum kept, and we performed PCR, and the Hep E was positive since 2 years. And this patient presented with a liver decompensation with ascites in a liver transplant patient. So this is really, I mean, a pity. He recovered. So we at that time we had ribavirin, and there was some positive signals for sofosbuvir, mainly in vitro studies, and we started ribavirin and sofosbuvir. Unfortunately, we could not achieve a sustained virological response, but the good news is that later on, with a new course of ribavirin and a new diminution of the immune suppression, he cleared he eliminated the virus. So just some words about sofosbuvir. There is one study that was performed in Germany that was used in patients that failed to achieve sustained virological response with ribavirin. And although they had in some patients antiviral action, they could not eliminate the virus. But the pity, in my view, is that in this study, the sofosbuvir was not associated to the ribavirin. So maybe if they had associated the two, the results would have been better. There are many case reports and with mixed results in HIV patients, in transplant patients mainly. So how to treat chronic hepatitis E? This is also from the European guidelines. And these guidelines are saying that the first step is to reduce immunosuppressive therapy. Sometimes when you diagnose an Hep E in an immune suppressed patient, you don't know since when he's infected. So I put earlier interrogation mark, because in my view, I would not wait until having 3 months of positive PCR to introduce ribavirin, but because some of these patients are already infected since many months or years. And as you see, this is not so good, as we have a sustained virological response of 81% after a 3 months course of ribavirin. And if you prolong in certain patients, you only achieve a 90% SVR. This means that the other 10% of the patient will certainly progress to liver cirrhosis. So this is really a challenge, and just one key message also is that when you start treating these patients, you should really document that you have a negative virus also in stool for 2 times, because if you stop too early riba, then the virus comes back. So for the treatment summary, the options are limited. In immunosuppressed patients, the key is to reduce immunosuppression or to improve immune response. The second step would be ribavirin. Wait to stop ribavirin until you have 2 negative stool PCRs. And sofosbuvir was disappointing, but maybe used in another way could be a solution for certain patients. And in acute severe presentation, you have to consider ribavirin. This is really very seldom that we introduce ribavirin in immunocompetent patients, but if the patient has a very profound jaundice and is not recovering early, we start ribavirin. This was the case of the man I presented. He had a very prolonged jaundice. He lost 15 kilograms, and we choose at one point to introduce ribavirin, which is not always easy to get now. This is another problem we have, at least in Lausanne, with riba. And for neurological complication, I mean, this is really a multidisciplinary discussion. Now the awareness among neurologists is really improved, and we are seeing more and more cases, and we really work and decide to get together about the treatment. And to finish, to say some words about preventive efforts. So as I showed the example of Ticino, I think we should increase the awareness of this virus among GPs, among population. I know I mean, many people don't know, and even cirrhotic patients are not advised not to eat some sausages and not to eat pork, and I think really this is not acceptable. So we have this, of course, systematic blood product screening, but since 2018, it was 4 years ago, individual advice with patients at risk. Also diabetic patients are at risk of more severe presentation, and it's not only pork but also game. And what about the vaccine? So we have 2 vaccines, but they are not licensed in Europe. The best studied is a Chinese vaccine that has proven high efficacy in large-scale clinical trials, but still we don't have it in Switzerland. So it's an important question. It was developed for genotype 1 and 2, but we postulate it may also be effective for other genotypes. It's a capsid-based vaccine, and it should work also. But of course, it would have to be tested, but there are not so many efforts to do it. I would not vaccinate everyone. I mean, but maybe immune-suppressed patients, patients with advanced liver fibrosis, diabetic patients, patients with hematological malignancies. These are the patients that, in my view, could benefit from a vaccine if we had it, but we don't have it in Switzerland. It's not only the case for Hep E. So just to say some words to advertise for my research, because if you see an Hep E in your clinics, I would be very happy to discuss with you, and also maybe to include the patient in a study, because my question now for my research is really to understand why some people are having so severe presentation. What is distinguishing these patients from the other patients that do not present severe presentation? And as you saw, the viral strains in our country are very homogeneous, so this is not the point of the virus. This is mainly something of the host. It's like for maybe, let's give the example of COVID. We know that individual factors influence the complications. So we, of course, pursue, every time we have a sample with the virus, we collect it for the antibodies to have a convalescent serum and also to genotype. But we also are now studying the factors of the host, and we are working now on genetics, and we probably found something in the individuals that without risk factors present a severe presentation. This is a collaborative study, and this is the challenges I think in 2022, but also for the next year. So in my view, there are still many questions to be solved. And just to thank all the colleagues I'm working with in Lausanne, and of course of Darius Moradpour, that is really the experts in our country and at the international level on Hep E.
How long would you have to cook pork liver to make it safe? How's it? Temperature and time?
20 minutes, 70 degrees. So this is not tasty anymore.
How high is the spontaneous clearance of the virus?
So this is an important question. So the spontaneous clearance of the virus is usually after 2, 3, 4 weeks. We don't find in immunocompetent patients, but the patient I presented you is a patient that I included in my study on genetics because he had a positive viremia for 8 weeks, and he was shedding the virus in the stool, and I advised that he doesn't share the toilets with his spouse for this reason. We should give the same recommendations that for Hep A.
Showed that most of the cases are only acute and quite a low number of chronic phases of Hep E. So is there an explanation for that? First question. And second, what happens with patients who were able to clear it? Is the virus really definitely gone, or maybe somewhere hidden in the body, similar like Hep B? And later in the life, when you have immune compromised situation, like an oncology treatment, that it comes back?
Maybe for this last question, no, it's not like Hep B. So when you clear the virus is gone. It's like it is very similar with Hep A, and there was a very nice review. I think there was CHUV, who is an expert on Hep A, that collaborated to this review with Darius, and they compared the two viruses, and it is similar to Hep A. So once the virus is gone, it's gone. Then, maybe there may be other consequences. Increased blood malignancy, for example. I have a huge number of patients that I follow, and I saw that, in my view, they have more hematological malignancy afterwards, but this is not proved, so we would need a big effort of all European experts to put all the cases together. This is ongoing. And the other question was, why do we have more acute than chronic cases? So first point, I think we don't diagnose every chronic case, and not every immunosuppressed patient will develop a chronic form. So this is it depends on the level of immune suppression. I think it's the point that explains the difference, but still I am convinced that we don't diagnose all cases.
The PCR test is paid, reimbursed by the health insurance?
We have always to be very cautious with the insurance. I never had a problem with PCRs, but you know, I heard that in German part of Switzerland there are now some problems with the Delta PCR, and I know that formally for Hep E it is not, how do you say, inscrit à la liste des spécialités. It is not formally accepted. So, but I mean, I never wrote a letter to the insurance to ask the possibility to do a PCR. I did it, and I never had any problem. But they could, in fact, they could maybe come back and say this is not automatically reimbursed.
As Hep E is now also has to be reported to the Federal Office on Public Health, do you have any data on the migration issue? Is it also a migration issue, or is it because it's only acute, it only happens mainly in
yeah, it happens mainly in an acute setting. So from immigration, we don't have data. It would be interesting to know the seroprevalence rates of patients coming from, for example, from Ukraine now, but these are data that are not known.
Is there any data if patients that had like genotype 3, if they were also immune against the other genotypes, or?
It is, we don't have this data, and we even have the proof that it is very rare, but some individual may reinfect. So it's not that the virus gets reactivated, but we have some individuals that had the proof of past infection, that kept IgM went down, and that got reinfection. And even one patient that was pretty severe, so you may be reinfected. So I postulate that if you get a genotype 3 and you can be reinfected by a genotype 3, you certainly can be reinfected by another genotype.
And I'm not sure if I saw it or not, but were there also patients that were treated with like antibody treatments?
No, that was in clinical practice, not done. But we have an interest in studying convalescent serum for maybe immune suppressed patients. That would be something interesting. But we, to my knowledge, in Switzerland, I'm sure for in other countries, maybe I don't know all the data, but it was not used.
Who should we test in our setting, in our addiction medicine setting? When should we think at Hepatitis E patients or Hepatitis E testing?
In your patients, there may be many causes of liver increased tests. Of course, toxicity with some drugs. Of course, reinfection with Hep C. This is maybe the most probable scenario. But I think every patient that presents with increased transaminases should be tested for Hep E. And I would do at the same time a PCR for Hep E. Probably if it is not an immune suppressed patient, HIV patient with low CD4, there will not be a consequence of this testing because it will clear the virus. But it's always good, I think, to document it and to understand the point. Recently, she's working with MSM, and she prescribed the how do you say it in English? PrEP. Do you use the same wording? And the liver test increased, and it is known that PrEP can increase liver tests, and that can be a toxicity. But I told her do a test for Hep E before changing everything, and it was Hep E. So it had an impact very important for the patient, and I think we have to know this. We have to look more frequently for the virus. Maybe, of course, I'm a little bit biased because this is a topic that has big interest for me, and but I'm convinced that we should test because retrospectively in some patients it helps deciding, these liver increase tests were not due to the medication, to the drugs, to Hep C. It was another thing, and we don't have to change the medication.
Thank you very much again for this very comprehensive, very clear talk on Hepatitis E. I guess we learned a lot and was excellent. Big applause for you. And
thank you.